Hello, ladies and gentlemen. My name is Jay Park. I would like to express my sincere gratitude to the organizing committee members for this kind invitation. I'm from Arizona School of Dentistry and Oral Health. Today, I would like to welcome you to my presentation, Interdisciplinary Treatment for Missing Teeth with Orthodontics and Temporary Anchorage Devices. Arizona is Grand Canyon State. We have lots of golf courses. I hope the Diamondbacks will do better this year. Next year, Super Bowl will be held in Arizona. First, I will talk about treatment for missing teeth. This article was published in the AJODO Clinical Companion. Her chief complaint was retrocline upper anterior teeth. She had a Class 2 Division 2 with a retained primary lower left canine. Pre-treatment dental models. Pre-treatment lateral cephalogram and tracing. She had a skeletal class 2 pattern with retrocline incisors. Pre-treatment panrex showing extrusion of upper sevens and missing lower sevens. Her ABO, American Board of Orthodontics, discrepancy index DI score was 31. If the ABO score is higher than 20, it is a difficult case. Let's review ABO scenario-based clinical exam, the domain 2, treatment objectives and planning. Treatment options for these patients are Truger surgery or upper force extractions with multiple mini screws. After discussion with the patients, this treatment option was chosen. When intruding upper anterior teeth, they should be located 3 mm below the stomium. The intrusion of upper posterior teeth would also be required to accomplish adequate upper occlusal plane 100 degrees in a true vertical plane to upper occlusal plane. For intrusion and palatal root movement of upper incisors and intrusion of upper molars, 3 tests were placed. When upper 7 super eruptions are prominent on the palatal cusps, mini tubes with 014 night-high wires may be a convenient and efficient way to intrude the over-erupted upper 7s before and after. This is a great clinical tip. Maybe clinicians should consider. When upper anterior teeth were sufficiently intruded, enough to make space for brackets bonding on lower incisors, mini tubes were replaced with braces. She had a missing permanent lower left 3 and it was replaced with a dental implant. A single TAD mini screw for intrusion of upper anterior segment tends to produce flaring and round tripping of the anterior teeth as the intrusion force passes through the anterior point of the center of resistance. When the entire dentition is connected with a continuous arch wire, counterclockwise rotation of the full upper dentition occurs on the rotation axis. To prevent flaring and induce intrusion of anterior teeth, a distal intrusive force must pass through the center of resistance of the full dentition. post-treatment porous after 32 months, post-treatment lateral sapalogram and saporometric tracing, post-treatment panel with an implant, saporometric superimposition before and after, comparison of the overbite before and after treatment. Our American Board of Orthodontics cast radiograph evaluation score was 16. If the score is lower than 27, you can pass American Board of Orthodontics traditional clinical exam. 3-year post-treatment porous, 3-year post-treatment dental models, 3-year post-treatment lateral sapalogram and saporometric tracing, 3-year post-treatment panoramic radiograph, saporometric superimposition. Her skeletal class 2 pattern and upper and lower incisor inclination have been improved. Now I want to talk a little bit about the lateral open bite with missing upper first premolars. Nathan's chief complaint was grinding his front teeth. He was 27.4 years old. Intraorally, he was missing upper fourth, anterior crossbite on his upper tooth and threes, and posterior crossbite on his upper fives, edge-to-edge bite on upper ones, and he also has bilateral open bite, right and left side. He was observed to have lateral tongue thrust habit with first opening of his lips when swallowing. You can see he is missing upper fourth and the rotation of lower left thigh. The upper right 3 root was close to the upper right 5 root. Lateral sapalogram, lateral sep numbers. He had a skeletal class 3 pattern, proclined upper incisors, and retrusive lips. He had no TMJ symptoms. His ABO DI score was 30. If it is higher than 20, it is a difficult case. He was referred to a general dentist to extract his third molars. To develop space for upper fourth, open coil springs were engaged. In the ABO scenario-based clinical examination, domain 3 is treatment, implantation, and management. We had to increase buccal overjet on his upper 6s and 7s. 1925 stainless steel wire was the main arch wire. Overlaying wire was 036 stainless steel. After activation, this article will be published in the JCO, Journal of Clinical Orthodontics. Ivan and Jose were my former residents. To expand the upper arch, we can use overlay arch to solve the transverse discrepancy. A heavy 036-inch stainless steel wire was overlaid onto main arch wire. It can be either inserted into headgear tube or engaged onto main arch wire with its terminal hooks. After we opened the space for upper fours, upper 3 roots were tipped distally. Now we have to control the root angulation. What is the ratio between the upper anterior torque and root angulation? I think we all know this article. In this article, Dr. Andrews mentioned about the wagon wheel effect. What is it? If there are 4 degrees of the labial crown torque, there is 1 degree of visual convergence of the central and lateral roots. The ratio is approximately 4:1. Progress panel showing the space opening for upper force using open coil springs. Because of the flaring of upper incisors, incisor roots were converged. Progress panel. Progress intraoral porous. He was sent to his general dentist to evaluate the restoration and the gingival recession on the upper left rib. After debonding, he had an anterior teeth restored but could not afford posterior restorations. Post-treatment dental cast. His upper incisors were proclined after treatment with decreased nasolabial angle. Here are the lateral SAP measurements. His skeletal class 3 pattern has been improved. Upper incisors were flared. The roots between the upper 3s and then upper 5s were diverged for future dental implants. His ABOCR evaluation score was 14. Our article was recently published in the Journal of Aesthetic and Restorative Dentistry. Pre-treatment facial and intraoral porous. She was missing upper left 5. Her dental midline was deviated to the left about 2 mm, and her lower dental midline deviated to the right about 1.5 mm. She also had an edge-to-edge bite. Pre-treatment panoramic radiograph and lateral sapphirograph. She had a skeletal class 1 pattern with a steep mandibular plane angle. She also had retroclined upper and lower incisors. After 12 months of treatment, a sufficient space was gained for upper left 5 by distalization of upper left molars. After 1 year treatment, distalization of maxillary left molars were stopped after sufficient space was created. The arm extension of MCCP was bent forward in preparation for maxillary protraction. For protraction force delivery, power chains were tied from palatal plate to TPA while maintaining the space for root replacement, tooth replacement. The panoramic radiograph showed that after extraction of lower left 8, a Raymer plate was placed for the distalization of mandibular dentition and midline correction. After 8 months of the mandibular distalization with a Raymer plate, the mandibular left quadrant was distalized and positive oval jet was established. A CBCT was used to check the implant location and angulation. The periapical radiograph taken at 1 month after implant placement confirmed the healthy bone healing surrounding the fixture and the healing cap. The provisional crown was delivered for upper left 5. Buccal and occlusal views after before and after gingivectomy. Total treatment time was 39 months, including the implant and orthodontic treatment. Post-treatment x-rays. Permanent implant crown delivery. Panoramic radiograph taken 1 month after delivery of the permanent implant crown. Saprophotic superimposition shows the proclination of upper incisors, retroclination of lower incisors, distalization of lower molars, and forward movement of upper lip. Post-treatment saprophotic measurements. Pre and post-treatment, you can see upper left 5 space was developed and restored by 1 implant. Now I'll talk about tooth autotransplantation. I present 4 cases with incomplete root apices and complete root apices. This is our case, which was published in the American Journal of Orthodontics and Dentofacial Orthopedics. In this case, the patient is missing lower 5s. Would you extract lower E's or keep them? So far, there has been no studies comparing the benefits or the risk of extraction of the lower E's with preserving them. Treating patients who have congenital absence of lower 5s with retained lower E's are largely at the discretion of the orthodontist. Retention of the primary teeth is likely to be a good long-term choice. Early infra-occlusion led to early loss of the retained tooth. Deciduous teeth that are 50% or more below the crown height of the neighboring tooth were considered in a poor condition. In patients with agenesis of the second premolars, 82% to 90%, 89% of the retained premolars were present at 5 to 13 years of follow-up. Infra-occlusion and root resorption did not seem to increase considerably. However, the evidence of this systemic review is considered low. 2.5 millimeter per each side in the mandible and 1.5 millimeter per each side in maxilla. The width of the lower E is 2 millimeter wider than lower 5. You have to consider this when you want to preserve lower E. In memoriam, I would like to express special thanks to Roberto Justice for sharing his precious memory of Dr. Profit. Dr. Profit was giant in our orthodontic specialty. This is the panel of the patients when patient was 11.7 years old. The patient was missing 4 premolars. Upper right 4 was transplanted to the missing area. We used a premolar from the heaven. Upper left 7 was not emerged and showed delayed eruption. After 26 months follow-up, the root is still a little bit short, but it shows a stable occlusion. After 26 months, the upper left 7 was emerged. Now I will share this article with you. This is patient pre-treatment intraoral porous. Records during the follow-up. The maxillary first premolars will be auto-transplanted to the primary mandibular second molar areas because patient is missing lower 5s. Progress intraoral porous. Transpalatal traction hooks were also used to distalize maxillary right segment for the midline correction after space closure. The active treatment duration was 25 months. Post-treatment radiographs. 12 months post-treatment porous. X-rays. According to this meta-analysis, systemic review and meta-analysis, survival rate of an open apex is 98% and closed apex is 96%. The success rate of an open apex is about 90%. The premolar had a lower failure risk than molars, and the root development stage and autotransplantation receptor site showed no statistically significant differences. The ideal treatment transplant tools has a root length greater than or equal to 8 mm and apex width greater than or equal to 2 mm. Please memorize these numbers. This case was published in the JCO. The patient is missing lower left 5 and retained lower left E. You can see patient is missing lower left 5. You may have different treatment options for this case. In this case, upper right 4 was transplanted to the lower left E site. After autotransplantation, orthodontic treatment started 6 months later. Usually we recommend nowadays about 6 weeks later in order to prevent ankylosis. 1 year post-treatment. In fully developed root canal treatment is usually performed 2 weeks after transplantation. 1 year post-treatment, CBCT image is showing the transplanted tooth. 30 months follow-up showed a stable occlusion. Panoramic radiograph also showed fairly stable results. This article was published in AJODO. The upper dental crowding was relieved by extraction of the premolar on the right side, and this extracted teeth was autotransplanted to replace the fractured tooth. Pre-treatment PanRex. The treatment plan included autotransplantation of upper right 5 to the lower left 4. This is the recipient site. In addition, extraction of the lower right 1 was planned, and this is the diagnostic setup model for final occlusion. And this is the transplanted, autotransplanted teeth. Pre-treatment intraoral porous. This is post-treatment intraoral porous after autotransplantation. It seems like this is a fracture line, but the patient has no symptoms. After 6 years post-treatment porous, panel is still stable. According to the systemic review and meta-analysis about completely root-formed autotransplantation, the failure rate, root resorption, ankylosis rates were occasionally in autotransplant teeth with complete root formation. However, the absence of systemic antibiotic therapy, endodontic treatment after 14 days, suture sprinting method, wire sprinting less than 14 days, and the posterior donor tools were influencing factors that aggravated failure rates. To prevent ankylosis, early application of orthodontic force about 6 weeks after transplantation may increase the success rate of autotransplanted teeth. And the tools that have occlusal contact prior to oral transplantation have a higher success rate than the tools that do not have a contact. It appears that if the proper surgical technique protocols followed, experience is not a significant factor for the surgical transplantation for surgeons. This patient is missing two upper laterals, and upper left third molar was transplanted to the upper right lateral and restored. Clinical photos 9 years after treatment, no periodontal tissues, no soft periodontal tissue, normal periodontal tissue are present on the transplanted tooth, and grayish area color is visible through soft tissues around implant site. You can see here. Approximately 1 in 50 children, 2% present with a missing maxillary lateral incisors, and in half of these cases are bilateral. In patients with missing bilateral missing or bilateral incisors, individual tooth widths and total tooth widths were significantly smaller than those in the control group. Layperson would prefer space closure for bilateral missing upper laterals to space opening. In patients with missing lateral incisors, orthodontic space closure, including first premolar intrusion and canine extrusion, does not cause risk of the periodontal tissue worsening or TMD in long term. Is there a difference in the space opening or space closing treatment duration when bilateral upper incisors are missing? There is no difference in treatment duration for space opening or space closing in bilateral missing laterals. Maybe you might be curious, what kind of restoration will you do for adolescent? Bicortically placed TAD can provide anchorage for the temporary upper lateral without interfering with vertical growth of the alveolus. We published this one in the Pedo Journal, a modified Pontic appliance for missing maxillary laterals. As you know, if the patient is missing lateral, a conventional Pontic is not stable, and common tie for adjacent tooth is not strong enough to hold it steady. A fixed aesthetic Pontic appliance, you can see here, on the first molar bands for the missing maxillary left lateral. And this is the 0.3-inch wire, and this is the lingual sheath on the molar bands. 2 holes are made on the labial side of the acrylic tooth and connected to the lingual side of the tooth through the channels using stainless steel ligature to increase the stability. This is the modified Pontic appliance, and it can be used as an anchorage for retraction of the canines. After canine retraction, the fixed Pontic appliance is now being used for the retraction of the incisors by slenderizing the 0.36-inch wire so that it can slide through the lingual sheath of the first molar bands. In order to open bite in deep bite cases, the modified Pontic appliance can be used in combination with the anterior bite brake. In this systematic review, the authors reported that space closure for missing upper laterals looks better aesthetically than prosthetic replacements. This is our CE article. Congenitally missing maxillary laterals. Orthodontic extrusion of the maxillary canines. You can see patient is missing laterals. Maxillary canine gingival lines are similar to the lateral incisors by extrusion. And then we do some occlusal equilibration of the canine cusps. And then composite restoration of the mesial incisor areas. And we have to consider the recontouring of the red areas of the maxillary canine to simulate lateral incisor. And enamel recontouring blue area of the maxillary first premolar for canine substitution. And recontouring red area of the prominent labial ridge of the canine before bonding the lateral bracket. And during the finishing stage, we can reduce the lingual surface. And also, to make canine appear like a less curved and more like lateral incisor, bracket is positioned more distally. And when you're substituting canines, you have to all consider these aspects. We should not talk of the brackets we are using. These are talk of the mandibular brackets. The main reason for using the central bracket is to the palatal root torque that will counteract the canine root prominence. And if you see carefully here, upper central incisor torque is 17 degrees, and lower second premolar torque is minus 17 degrees. So it's opposite, okay? But numbers are the same. So we see this one next slide. And this is the tip of the MBT prescription. Here you can see the canine root prominence. And if you are doing the canine substitution, we have to consider how we can reduce this canine root eminence. Common bracket choices for substitute maxillary right canine. Upper right 2 bracket provides slightly greater torque, and upper right 1 bracket even more, but we have to consider enameloplasty before bonding. What about on the right side? Let's look at this one. A flipped bracket canine is recommended, but it may not provide enough labial lingual root torque of the canine. But as I showed you in the previous slide, we can use the lower 5 bracket in the opposite side, and by flipping this wire, we can express 17-degree torque. So this might be an efficient way to express lingual root torque to reduce the canine eminence. But we have to use the opposite side of the lower left 5. If this one is upper right 3. So we also can use Warren spring for lingual root torque to reduce the canine eminence. So usually for the Warren spring, if we are using the auto-strap bracket, we can use 1925 or 1825. And also we can consider some step out bend. I will show you in the next slide. The labial step out bend in arch wire as the palatal root torque and the reduced occlusal trauma on mandibular incisors while improving the interproximal contact between upper 1 and 3. Pre-treatment porous, pre-treatment panrex, post-treatment porous after treatment, Okay, I wanna discuss something here. First molars are substituting maxillary canines. Although this is the second premolar here, second premolar, it just look like if you put bracket a little bit more distally, and then you can rotate it, the premolar, and it looks like more like a canine. So to improve also position of the canine, like first premolar like canine, it should be, we have to put bracket more distally and for rotation, and also it is necessary to position this bracket more occlusally to permit intrusion to coordinate the gingival margins. 2-year post-treatment after restoration of anterior teeth, 2-year post-treatment Panrex. Now I will talk a little bit about transalveolar transplantation. It is different from the autotransplantation. Transalveolar transplantation is transplant to the same area, but autotransplantation is transplant to a different location. This is from the AJODO article in 1986. When she was 15 years old, the root of the lateral incisor was resolved by impacted canine. After space opening, transalveolar transplantation was performed. This is 8 months post-treatment. Renard was 17 years old, and his chief complaint was retained baby tooth. You can see the retained baby tooth here. Pre-treatment Panrex with impacted canine. Pre-treatment X-rays. Canine was palatally impacted. So the movie is not working. Let's go to the next one. So progress porous. We didn't include the bracket here to prevent root resorption, and they were bonded just before surgery. You can see the space regaining. So upper right C was extracted. And upper right 3 was transplanted, but there is a bony defect on upper right 3 root area. And this is after transalveolar transplantation. Upper right 2 was diagnosed necrotic by her endodontist. So after root canal treatment on upper right 3 and upper right 2. 6 months after treatment, the impacted canine was well aligned after transplantation. He had a thin labial bone plate. After 13 months of treatment, because of the thin labial plate, torque control on the upper right 3 was not fully expressed. Post-treatment Panrex. Saporometric measurements. Upper incisor shows more normal inclination. Although the rate of the complete success in this study was low, about 38%, the survival rate can be considered favorable, which was about 83%. We might consider transalveolar transplantation as treatment option for extremely mal-positioned canine with mild occlusion, mild malocclusion. So before you do the transalveolar transplantation, we have to be careful for the extraoral time during transplantation, damage to root surface, and post-operative oral hygiene. Now I will talk about molar protraction with mini screws. Key factors in molar protraction with temporary skeletal anchorage devices. These are my articles and books I will talk today. First, I will talk about biomechanics in molar protraction. What are biomechanical considerations during molar protraction with mini screws? If we protract the whole maxillary dentition with mini screw, around center of resistance, there is a moment which induces anterior open bite. Now, let's go to our main topic. If the molars are being protracted around center of resistance, the occlusal plane will rotate and anterior open bite can occur. During molar protraction, lower molars can also tip mesially. What are biomechanical considerations during molar protraction with mini screws? During molar protraction, a round hook can be used to prevent tipping of the posterior teeth. Armriding spring can also be used. For molar armriding, we can use the prefabricated armriding spring and the mark between anterior band between the lower 3 and 4. For simultaneous armriding and intrusion, the band in anterior region will be about 135 degrees. For armriding and extrusion, 90-degree band can be made. In adults, molar armriding can cause furcation involvement, mesial bone loss, and increased tooth mobility due to the extrusion and poor oral hygiene. Whenever a part of the tipped molar crown is above the furcation functional occlusal plane, optimal technique should be applied with intrusive force to the molar to reduce the TFO and further attachment loss. Dr. Jackelson also mentioned improved molar armriding with mini screws. During molar protraction, occlusally, mesial lingual rotation and buccal crown tipping can occur. To prevent this side effect, a balancing lingual force can be used. This problem can be minimized by inserting toe-in band in the posterior portion of the arch wire. Dr. Che is a visiting scholar at my program. Running loop wire can be delivered 25-degree tip-back band. If there is an anterior crowding, posterior power chain can be activated from molar tube to the premolar area. Mini screw also can be used as an anchorage to protect posterior teeth. If power chains are applied from buccal and lingual side, toe-in is not necessary. Okay, please remember this one. How can we, here you can see the progressive mesial movement of the running loop to cross the space. In missing lower 5s, bodily movement of the molar was achieved, according to our study, when amount of the tip back and toe-in angles was 12 degrees and 10 degrees respectively. A mini screw can be also used as a running loop to cross the space. In missing lower 6s, according to our study, mesial translation of molar was achieved when amount of the tip back and toe-in angles was 11 degrees. This was the top downloaded article in orthodontics and craniofacial research. This shows the summary table of the running loop for tip back and toe-in bend. You might be curious, unwriting technique, which unwriting technique is better? In this study, the authors demonstrated molar unwriting with TAD shows the distalization and intrusion compared to others, which shows the distalization and extrusion. And the mini screw had the least, and the cantilever had the greatest strain on the root region. In other words, if you use the cantilever spring, it can cause much more root resorption of the tooth. During molar protraction, to prevent tipping, a long hook can be used. But clinically, usually patients comes like this. How would you unwrite this tilted molar without side effect? Do you want to use continuous nitride wire to unwrite tilted lower 7? The tilted molar can be unwrited by mini screw supported unwriting spring. It can unwrite molar while extrusion and the distal crown movement can be counteracted by intrusive protraction force from the mini screw. Continue unwriting, then protraction for space purging. This is a study which was published in JADA by my colleagues in Korea. The mean age of this study was about 23 years. The authors measured root lengths and alveolar bone height on panorax. They measured the amount of the crown movement and root movement on the superimposed lateral cephalogram along the mandibular occlusal plane. In this study, they found after molar protraction, root resorption and alveolar bone loss have occurred, but they were clinically acceptable range. Greater amount of the root movement were risk factor for root resorption, and increased patient age was risk factor for alveolar bone loss. When using TAS for molar unwriting, we can use indirect or direct method. 19-year-old female patient with visually tipped lower 7 before treatment. With indirect mini screw anchorage, lower 7 was unwrited with rectangular TMA unwriting spring. However, you can see alveolar bone loss after unwriting the lower 7. In my book, let's take a look at Dr. Kim's chapter. After extraction of the third molar, a TMA arch wire was used for unwriting lower 7. Superimposed pre- and post-treatment models after unwriting. 12-year-old female patient with visually tipped lower 7 before treatment. We can use a direct mini screw anchorage. First delivery, 16 stainless steel wire with welded hook. An open coil spring was used. After 3 months and 5 months of unwriting, according to Dr. Chen, the molar tube can be bonded on the occlusal surface of the impacted tooth, and the tooth in front of the impacted tooth can be bypassed. Partially impacted lower 7. This is very interesting article I want to share with you. Maybe you can share with your surgeons. This is partially impacted lower 7. After surgically assisted forced eruption, you can see not only surgical luxation, but also we can bring the impacted tooth upward. So horizontally impacted lower 7 and unwrited to a partially erupted position and unwrited and follow up. So after unwriting, minor occlusion, we can consider minor occlusal reduction. to reduce the occlusal interference, and the root development appeared to be mildly affected by this surgical procedure. So you can consider this one, this surgery procedure with your surgeons. Okay, so during treatment or after orthodontic treatment, we have considered the eruption of the lower 7. Sometimes they are horizontally impacted. And in the previous slide, I told you about transalveolar transplantation and autotransplantation. According to this literature, if the angle between the long axis of the lower 6 and 7 is greater than 75 degrees, surgical luxation might not be efficient to unlike lower 7. In this situation, we might consider transalveolar transplantation. Now, I'll show you some clinical cases. You can see the video on this article. This is our article in AJODO website. Her chief complaint was protrusion of the upper anterior teeth and upper lip. She was 22 years old and referred for evaluation of orthodontic treatment. She showed slightly lingual crossbite on upper right 6 and buccal crossbite on upper left 7. She was missing lower left 6 and lower left 8 was horizontally impacted. She had a skeletal class 2 pattern and her overjet was 8.5 mm. You can also see proclined upper and lower incisors with skeletal class 2 pattern. She also had protrusive lips. How would you treat this case? You can have an extraction treatment plan on the upper arch and space closing on the lower arch. These are the alternative treatment options for this patient. Let's talk a little bit about posterior crossbite correction. Mandibular posterior crossbite appliance can be used for buccal traction or lingual traction. Intraoral photo showing the correction of the ectopic upper right 7 with a modified lingual appliance. A tooth in crossbite should be intruded first, and then it can move either buccally or lingually. So intrusion first, then move it buccally or lingually. My research team in Korea and I wrote this chapter together. These are treatment approaches for the seizure bite correction. I think these are all valuable treatment options. 18-year-old male patient with skeletal class 3 pattern, pre-treatment porous and dental models. When guiding the model to the post-surgical position, a severe posterior seizure bite can be expected. Pre-treatment X-rays, initial alignment before surgery, path in the palatal slope area is a direct anchorage for seizure bite correction. And after treatment is done, we can modify the retainer for buccal springs. Post-treatment porous, lower 5s are dental implants. 2 years and 6 months of post-treatment porous. And this is a pre-treatment. Okay, having all this information, how to correct crossbite, let's go to this case again. Her complaint was protrusion of the upper anterior teeth and upper lip. How would you treat this case? To correct her upper left buccal crossbite, a modified TPA with soldered hook was used with pouch chain. To correct upper molar crossbite, extension arm and pouch chain can also be used with a TAD. On the lower arch, modified lingual holding arch with soldered hook was used. To allow clearance during crossbite correction, a removable appliance was also delivered. To correct lower molar crossbite, an extension arm and pouch chain can also be used with a TAD. Progress photos showing the space closing of the upper arch and protraction of the lower 7 using TADs. Progress radiograph images showing the protraction of the lower 7 and unwriting of the lower 8 with a modified lower lingual holding arch and soldered hook. After treatment, the missing lower left 6 space was successfully closed and the lower left 8 was successfully unwrited. You can also see the improvement of her oval gel. Upper incisors were retroclined and the lower incisors were slightly proclined to correct her oval gel, and her soft tissue profile has been improved. This is our saprophytic superimposition, pre and post treatment. Let's talk about a little bit about the modified Hartmann apparatus. An ectopically erupting lower 6 can be managed by using modified Hartmann apparatus. Intraoral photos showing the correction of the impacted lower 7s in a different patients with a modified lower lingual holding arch and soldered hooks. However, after we deliver this apparatus, the patients often come to the clinic with soft tissue irritation. How can we reduce this side effect? We can use a different apparatus. In this apparatus, compressed nitrile spring generates mesial and distal forces, and distal force is applied at the level of the lower 8th, and around center of resistance, there is unwriting movement and distal force. While the wire slides through the slot of the miniscrew head, you can see the distalizing and unwriting of the lower 8. Buccal unwriting force generates clockwise movement of the third molar, causing distal rotation. To counteract this side effect, wire is bent distally before insertion into the molar tube to generate counterclockwise movement. This is my patient Joe. Wire is bent distally before insertion into molar tube to generate clockwise movement. Top panel shows a modified Hartmann apparatus, and the bottom panel is using a miniscrew anchorage. The lower 7 is almost unwrite now. Now I want to share the prefabricated sandal spring. This also can be combined with miniscrew to unwrite a molar. As I told you before, for unwriting and extrusion, 90-degree bend can be made between 3 and 4. For simultaneous unwriting and intrusion, a bend in anterior region will be about 135 degrees. 30 degrees of the V bend can be applied for activation of the unwriting spring. I also tried prefabricated unwriting spring for the same patient using a direct miniscrew anchorage. This is 1 month after treatment. So after treatment. This is an interesting case from my colleagues in Korea, Dr. Jang. Let's briefly review this case. This patient's cheek complaint was broad bite on his left side. How would you treat this case? We made a table for this study. In this Boston University study, the authors developed a transverse analysis based on the CBCT, which can differentiate between the skeletal and dental transverse problems. We also have to know the norm of the transpalatal width at the cervical region of the first molars. In other words, it's about 37 millimeter, and for mixed dentition, it's about 34 millimeter. You can see the buccal crossbite here. In order to allow clearance during crossbite correction, posterior bite block was placed. The upper tooth was intruded bodily, and the lower tooth was intruded and unrighted. Before and after treatment. Now I would like to share this article with you.
Thank you for your interest in our video presentation. This is a case report entitled Correcting Severe Scissor Bite in an Adult. This case report is authored by Drs. Woonbong Baek, Yoonji Kim, Junji Sugawara, Christine Hong, and Jaehyun Park. This case was treated by Dr. Woonbong Baek of Smile with Orthodontic Clinic located in Seoul, Korea, and this presentation is narrated by Dr. Christine Hong. This is our 28-year-old female patient with the chief complaint of scissor bite. Patient presented with skeletal class 2 pattern with A and B of 4, and her lips were protrusive. Intraoral examination revealed a class 1 molar and canine relationship on the left side. The patient had 5 mm overjet and 30% overbite. The maxillary arch had moderate crowding with proclined incisors, and the mandibular arch had severe crowding with lingually displaced right posterior segment. Let's take a closer look. Patient had a severe scissor bite. The upper molars occlude with lower ridge with extrusion of maxillary molars. Lower posterior teeth are lingually tilted at a 90-degree angle. You can appreciate this from the lingual view as well. Mandibular basal bone was also affected, and there was asymmetric mandibular constriction on the right side. Scissor bite does not get corrected spontaneously. It progressively worsens as maxillary teeth continue to super-erupt and mandibular teeth continue to tip lingually as in her patient. If it is not corrected, mandibular posterior teeth can be lost. Untreated scissor bite in younger patients can lead to abnormal jaw growth and development of facial asymmetry. If this patient comes to your office, how would you treat this case? Surgery was recommended to the patient as a first treatment option. However, patient declined the surgical treatment. This is the overview of our non-surgical correction of severe scissor bite in an adult patient. For maxilla, we used TSAD facilitated posterior intrusion with 2 TSADs for balanced biomechanics. For the mandibular molar uprighting, we chose not to use TSADs in this case. Instead, a modified lingual holding arch was delivered to the mandibular arch. During the mandibular uprighting, patient used a maxillary bite plate. After 7 months, scissor bite correction was successfully achieved. The maxillary right molars were intruded. The mandibular right molars were buccally uprighted. By uprighting the mandibular right posterior teeth, we were able to reposition the alveolar housing as well and relieve the mandibular basal bone constriction, which led to long-term stability. If you're interested in learning more about our case, you can find it in AJODO July 2019 issue.
Okay, thank you. So Maria was referred to me by her general dentist, and her cheek complaint was anterior crowding. This is pre-treatment panel, and she was missing lower 6s, and you can see the lower third molars are tilted. She had a skeletal class 2 pattern, and then after 34 months of treatment, upper incisors were retroclined to improve her overjet, and this is the after post-treatment cataracts. And upper incisor was slightly retroclined to improve her overjet. And I published this article with Dr. Richard Williams and Jimmy Baden. And Kara was missing lower Y6. And her dental midline was off, and she had a straight profile. This is her pre-treatment cataracts, and you can see lower Y6 is missing. She showed skeletal class 3 pattern with a proclined upper incisors and retrusive lips. And I used the mini screw for molar protraction. This is after 23 months of treatment and post-treatment cataracts. There was a slight improvement of the skeletal class 3 pattern, and proclined upper anterior teeth were slightly improved, and the lower anterior teeth were slightly retroclined. However, there were no significant changes of her retrusive lips after treatment. Now I would like to share Dr. Lai's article about arm-riding molars with twisted 180-degree night-tie wires. He's a faculty at NYU. My right side is Dr. Lai, and the left side is Dr. Shafira. To generate buccal crown torque, a twisted 100-degree torque wire can be applied with heavy rectangular wire. Okay, I want to show you a movie. This is a lower arch. The wire was twisted 180 degrees to express buccal crown torque. Twisted 180-degree torque wire was applied to the upper Y6, which was in buccal crossbite, and this is after 4 months. Okay, so I will show you a movie. This is an upper arch. The wire was twisted 180 degrees to express finger crown. So I modified also 180-degree torque in this case. The main arch wire was cut on the lower right one to express labial root torque. And twisted 180-degree labial root torque was applied and overlaid on the main arch wire. And you can see the improvement. So I will show you the movie. The wire twisted 100 degrees to express finger crown torque of the insect. Our article was published in the JCO, and the treatment plan was to extract upper fourths and hopeless lower posterior teeth. The lower left posterior extraction space was approximately 15 millimeter, was about 15 millimeter. The lower missing space can be crossed by protracting the posterior teeth. 1 year after treatment, 3 years of post-treatment. Post-treatment dental casts, post-treatment radiographs, saporometric superimposition. As I mentioned, during molar protraction, a long hook can be used to prevent tipping of the posterior teeth. We can use indirect anchorage to protect the posterior teeth. A lever arm hook, can be used to prevent irritation of soft tissue by engaging pouch chain. If we modify the design of the wire bending, we can increase the activation distance. In my book, these are the images from the Dr. Choi and molar protraction with tests. I think this molar protraction appliance is too bulky. Dr. Choi and I made designs for molar protraction. These are designs for molar protraction. If the patient has enough clinical crown, we can add 036 buckle tube for molar protraction. And after we insert 032 stainless steel wire, we can use indirect skeletal anchorage for molar protraction. We can bond 036 buckle tube for molar protraction. To accommodate 032 round wire, we can use a precision lingual bracket and hinge cap after protraction. Or we can protract the terminal molar using conventional molar tube. However, compared with two previous designs, this design is less stable and can cause vertical or horizontal bowing effect due to thinner wire size. Therefore, in this design, to reduce side effect, we might consider second order band and buttons and pouch chain on the lingual side. Sometimes adult patients visit our office with missing first and second premolars. This article was featured on the cover page of JCO. Before we start orthodontic treatment in edentulous ridge areas, the edentulous ridge can be classified to consult with your periodontist. Siebert class 1 is defined as the buccolingual loss of the hard and soft tissue contour with normal vertical height. Siebert 2 is vertical loss of the tissue contour with normal buccolingual width. As you expected, Siebert 3, class 3, is combination of class 1 and class 2. This 35-year-old female patient is missing 2 premolars on her right segment. One treatment option was to extract upper 4th, and due to the significant amalgam restoration, extract lower left 5 and close the extraction spaces. This space can be restored by implant after treatment, but patient declined this treatment because she didn't want to have an implant. So final option for this patient might be close all the spaces. And the missing area showed Siebert class 1 ridge classification. These are the photos after 22 months of treatment. And for during the space closing, you can engage the separator ring to activate this closing loop here. And then this will be also decrease patient discomfort. After 32 months of treatment and x-rays, and after treatment, the posterior mandibular teeth, posterior teeth moved forward. In our patients, CBCT was to identify descents on the lower right 6 and lower right 3, which were insignificant compared to those in other regions. 4 years after debonding, x-rays. This is class 1 dental relationship. In class 2 molar occlusion, after extracting upper 4th, full class 2 molar relationship can be established. In class 3 molar occlusion, after extracting lower force, full class 3 molar relationship can be established. In class 3 molar occlusion, before extracting lower force, please check if the patient has lower eighths. Otherwise, the upper sevenths can be extruded. According to the different extraction patterns, sometimes it is very critical to keep upper and lower eighths. We published these articles in the JCO and Pedo journal. In my new book, let's take a look at Choro's chapter, Dr. Beck's chapter. Placing the elastic thread directly on the hook to the TAD results in retraction and intrusion of the anterior teeth. Placing the thread on the hook to the TAD after passing over the arch wire results in the anterior retraction and more intrusion of anterior teeth. Placing the thread on the hook to the TAD after passing over the arch wire at the major part of the first molar results in retraction of the anterior teeth and intrusion of the posterior teeth. And also, we can, by passing over in this way, we can protract and intrude the posterior teeth. Now I'll summarize today's lecture. When upper seven superimpositions are prominent on the palatal cusps, mini tubes with 014 nitrile wires may be a conventional and effective way to intrude the over-erupted upper sevens. For a missing tooth, adjacent root can be diverged with the orthodontic treatment to provide space for future implants. Multidisciplinary specialists can effectively treat the permanent tooth agenesis with the implant restoration using orthodontically regained space. And autotransplantation is a viable option for missing teeth. And during molar protraction, we have to consider the side effect and should know how to prevent them. According to the literature, if the angle between the long axis of the lower 6 and lower 7 is greater than 75 degrees, the surgical luxation might not be efficient to unlike tilted lower 7. In this situation, we might consider transalveolar transplantation. I would like to express my great appreciation to all those who helped me to carry out the research, and these are my residents and faculty members. And this is my contact information. My email is jpark@atsu.edu. And dear colleagues and friends, thank you so much for your kind attention. And if you have any questions, please let me know. Thank you.